Well, good evening, everybody, and welcome. I'm State Senator Jason Lewis. Thank you so much for joining us for our community conversation on the fight for reproductive justice and freedom. I've been hosting community conversations for several years. The goal of these conversations is to shed light on important issues that are affecting our communities and to help foster constructive dialogue. I want to thank Sarah Zyberg and Zach Crowley from my office for all of their hard work organizing the event tonight. I believe that access to quality, affordable health care is a basic human right, and that this most certainly includes reproductive health care, including access to abortion. With the shocking Supreme Court decision in June to overturn Roe v. Wade, which had stood for 50 years, many Republican-led states have already moved to completely ban or severely restrict access to abortion care. They are even taking steps to criminalize healthcare providers or others who may assist a person in obtaining an abortion. This is a frightening situation for reproductive justice and freedom in this country. Here in Massachusetts, I'm proud that our state legislature has taken decisive action to protect and to expand reproductive rights. In 2017, we passed what is known as the Access Bill. This law requires health insurers to cover all FDA-approved contraceptive methods with no copay, including over-the-counter emergency contraception. Also allows consumers to access up to a 12-month supply of a prescribed contraceptive at one time. In late 2020, we passed what is known as the Roe Act, which required the legislature to override a veto from Governor Baker. This critical law ensures that the right to an abortion is enshrined in our state statutes, and it also removed some burdens that unnecessarily denied or delayed abortion access. And then in July of this year, in response to the Supreme Court ruling, we passed another bill to protect healthcare providers from any liability for providing reproductive or gender-affirming healthcare. Law enforcement is prohibited from cooperating with other states who have criminalized abortion care. Health insurers must cover abortion and abortion-related care with no cost sharing. In addition, I was proud to lead the effort, along with State Representative Lindsay Sabadosa, to include a provision in this bill that requires our public college and university campuses in Massachusetts to ensure that their students have access to medication abortion services. None of this progress happened on its own. It took hard work and grassroots activism from many dedicated and courageous individuals and organizations, three of whom we have with us tonight for our panel. Despite this progress that we have made, as significant as it is, there is still much more that can and should be done to advance reproductive justice and equity and freedom here in Massachusetts. Just yesterday, you may have seen a story in the Boston Globe where they reported on how in some parts of the state, patients have virtually no access to any abortion providers, forcing them to travel significant distances. The cost of care can also still be a barrier, especially for people who have to travel here from other states. And Massachusetts, like the rest of the nation, suffers from maternal health disparities in access to prenatal and postnatal care and in disturbing maternal health outcomes for people of color. Tonight, we are very fortunate to be joined by a fantastic panel of experts who have been deeply invested in this work and will help us all better understand the reproductive justice landscape, as well as additional steps we should be pursuing here in Massachusetts. After each panelist provides her opening remarks, we will then turn to your questions. Please write your questions in the Facebook comments as we go along. My office has also put together a resource guide for folks who are interested in learning more about this topic after our conversation. And you can find the link to this guide also in the Facebook comments. All right, so without further ado, it is now my pleasure to welcome and introduce our first panelist. Claire Teylouni is the Director of Government Affairs for Reproductive Equity Now, which was previously known as NARAL Mass. She joined the organization in August 2021 after nearly 7 years of public service experience at both the state and federal level. Claire graduated from the University of Denver with a double major in political science and environmental science. Claire, welcome. Let's bring you up on the screen, hopefully. Great, there you are.
Thank you so much, Senator.
Thank you so much for being with us tonight. It's great to see you again. So perhaps you could get our conversation started by telling us, a little bit about yourself, the work of Reproductive Equity Now, and how you see the current state of reproductive rights and justice in Massachusetts and across the country.
Absolutely. Well, let me just start by saying thank you so much, Senator, for hosting us and for having this conversation this evening. It's so important, and I'm really excited to be a part of it. Like you said, my name is Claire Teylouni. I am the Director of Government Affairs for Reproductive Equity Now, which, as folks may know, was formerly NARAL Pro-Choice Massachusetts. I've been with the organization for a little over a year now, and it's been a really incredible year to be joining the reproductive healthcare movement and advocacy space, particularly in Massachusetts, which, Senator, as you described, has been a leader on reproductive freedom issues for a very long time, from the access law codifying contraceptive access in Massachusetts to repealing archaic abortion laws that we had on our state statute, to the Roe Act in 2020, which codified the right to an abortion. And in the past year, thanks to the Roe Act and in the lead up to what we knew would be the coming decision in June in Dobbs v. Jackson, we knew, thanks to the Roe Act, that abortion would remain legal in Massachusetts. But one of the things that Reproductive Equity Now really focused on in its conversations with advocates and with legislators was making clear that that statute hasn't made and wouldn't make Massachusetts immune from the crisis of the potential overturn of Roe v. Wade. And what we saw would be the overturn of Roe v. Wade when the Dobbs leak came out. The draft opinion was leaked because this is a national healthcare crisis, and we knew that the cascading impact of abortion bans in other states would be coming to Massachusetts. And we've seen from conversations with providers over the past year that who have been seeing patients from Texas in the year after their 6-week ban went into effect, whether they knew they could get a direct flight to Massachusetts, whether they simply knew that they would be safe in Massachusetts or they had friends to welcome them here. And so we knew that because abortion remains legal, we had a strong statute that was the foundation and the legal framework for that. But we've been very adamant that legality is not synonymous with accessibility. And there are always steps to be taken, whether it's public awareness, policy solutions, or otherwise, always steps we can be taking to improve access to abortion care. And so when the Dobbs v. Jackson leak draft opinion came out, we at Reproductive Equity Now worked with partners at the ACLU and at Planned Parenthood to release what we called the Beyond Roe agenda, which was a 21-point plan to protect and expand access to abortion care and reproductive health care more broadly in Massachusetts, because we knew the fight for abortion rights was happening at the state level, and we knew we needed a coordinated and comprehensive game plan to protect reproductive health care from all angles, because as you've introduced, obstacles to care, even in Massachusetts, still very much exist, whether it's under-resourced providers, exorbitant costs and financial barriers to care, or complex insurance coverage. And so we are very excited that throughout a whirlwind end of the legislative session, formal session in July, many of the recommendations of the Beyond Roe agenda were included into the comprehensive package that the legislature passed at the end of July and was signed into law at the end of July, including, as you mentioned, Senator, best in the nation protections for providers from out of state hostile litigation, for providing both gender affirming care that's lawful, as we know, in Massachusetts, and abortion care that's lawful in Massachusetts, an insurance coverage mandate for abortion without any cost sharing, as well as a confidentiality program for providers so that they don't have to face threats of violence or harassment at their own homes, improved access to emergency contraception, which is a really exciting provision, and as you noted, Senator, your provision to help public colleges and universities implement plans to offer medication abortion. And so I think in terms of improving access in Massachusetts, this is a really historic and extraordinary piece of legislation. And in addition to that, as you know, in the annual budget that the legislature passes every year, also for the first time invests $2 million in reproductive healthcare access infrastructure, as well as support for the abortion funds in Massachusetts, which is an incredible step and an incredible way to break down financial barriers for folks who need access and help paying for abortion care. So it was a really exciting piece of legislation that got over the finish line because legislators like yourself saw the urgency of the need for places like Massachusetts to really step up and continue to be a leader. And we, I think, as advocates at Reproductive Equity now, are very excited to focus on implementing several of the provisions of this bill, and as well as brainstorm, new ways to be making sure that Massachusetts is taking stock of the impact of the Dobbs v. Jackson decision on access in Massachusetts and continuing to explore ways to be a leader on reproductive freedom issues.
All right. Thank you so much, Claire. You really did a phenomenal job setting the stage for us. And I'm glad you mentioned the Beyond Roe agenda, because I'm sure we're going to want to return to that this evening and discuss what we haven't yet implemented from the agenda. But now it's my pleasure to welcome and introduce our second panelist this evening, Katherine Rushfirth. Katherine is the Policy Director at Neighborhood Birth Center, which offers comprehensive midwifery care throughout pregnancy, labor, birth, and the postpartum period by integrating an independent, freestanding birth center in Boston's healthcare and community landscape. Katherine is a full-scope midwife with a long-held commitment to health equity and social justice. Prior to joining Neighborhood Birth Center, Katherine was the Associate Chief of Midwifery at Mass General Hospital, where she spearheaded programs to address the social determinants of health and expand family planning services to our community health centers. She was among the first midwives to be named faculty at Harvard Medical School. She completed her midwifery education at Yale University and her BA in Women's Studies and Anthropology at Barnard College. Katherine, it's great to have you with us tonight. Thank you. Could you please share with us what draws you to the field of reproductive care and advocacy, and your thoughts on how to improve maternal health outcomes and advance reproductive justice more broadly here in Massachusetts?
Yes, thank you so much, Senator. I'm really thrilled to be here with such wonderful people on this panel. Again, just to introduce myself, my name is Katherine Rushfirth. I use the she, her pronouns. I am thrilled to be here representing Neighborhood Birth Center. Our fantastic executive director, Nashira Burrell, is actually down in Atlanta doing work with Birth Center Equity. Otherwise, she would have been here tonight herself. Neighborhood Birth Center is a nonprofit organization working to open the first freestanding birth center in Boston. And specifically, we're hoping to open in the Roxbury neighborhood. And it, as you said, it is to expand access to midwifery care. And so not everybody knows what a birth center is. So just to give some context, birth centers are, some people say home-like or spa-like environments, but they're out of the hospital environments where people can access full scope midwifery care. So certainly prenatal care, you can give birth there, but fully comprehensive postpartum care, family planning care, and we are going to provide abortion care there as well. And despite kind of a lot of the rhetoric in the public around pregnancy and risk, the CDC estimates probably 85% of pregnant people would be totally well served and qualify for midwifery care. And of those, many, many, many should be offered and would benefit from birth center care. There's decades of research around the outcomes for midwifery care, and some very, very strong research recently around specifically midwifery-led birth center care. So that the midwifery and birth center care, they're providing not just the same, but they are in fact have improved outcomes for pregnant people and their babies. They have much higher patient satisfaction rates. They have people with much more supported postpartum courses. And this all comes at a great cost saving to the health system. So neighborhood birth center, the goal is to try to open either late 2023 or early 2024. And it's not only to offer really, really high quality care in the Boston area, but to serve as a model kind of statewide and nationally on what it really can look like to provide equitable healthcare and the opportunity for transformational births. And this is particularly because Neighborhood Birth Center is a Black-led organization, which means that it joins the less than 5% of birth centers nationally led by people of color. It is explicit in its mission to center the experience and the joy of Black families, while at the same time improving care and improving the standard of care for all people. And I will tell you, at every process of its development, whether it's the organizational structure or the work values or the community engagement, everything has been done very, very deliberately to try to dismantle the structures of white supremacy and heteropatriarchy that kind of are the bedrock of a lot of our healthcare institutions. So specifically because I've joined this organization, and also I think the topic of the panel tonight, I really want to be very clear and explicit about my own identities and what I kind of bring to this work, and how I'm going to be framing my discussion tonight. So I am a certified nurse midwife. Most of my clinical work has been in a hospital system or in community health centers. And I'm also an abortion provider. So I have that perspective as someone that has been in the field. I am white, I am queer, I'm a cis woman. I am a feminist, proudly. I am both a sexual assault and a domestic violence survivor. I'm a mother. I gave birth. My oldest one is turning 3 next week. And you may not be able to tell from this up, but except for the fact I keep running out of breath, I am 9 months pregnant with my second child. And why I want to name that is because all of those identities, like for all of us, they bring me to the work, they inform my work, but particularly in the areas of great privilege that I have, they can be blind spots or areas that there's potential to do harm in this work. So I think we're going to talk about it, about the origins and the leadership of reproductive justice, but just so people understand that the movement leaders, where that comes from is specifically with Black people and largely Black women. So I am going to be speaking about this really as a white person in this sphere and in this work, with all the limitations and complexity of that, and really probably directing a lot of my conversation to other white people, whether it's birth workers, advocates, people in the political world, basically of like how we can have these conversations amongst ourselves and really, I think, join this movement, or the sense that our liberation is also tied to this. And so that this system as we have it now is failing everybody. It doesn't work for anybody. And we've been sold kind of a false narrative that either it is working or it's what we have to tolerate or it's the best we can do. So I'm really happy to be here tonight. I'm really happy to hear from these other wonderful panelists and advocates about kind of how we can really reimagine a much more liberatory model and move forward in allyship and in partnership. Thanks.
Katherine, thank you so much for your powerful remarks, and you've really teed up some very important topics that we will be exploring in more depth tonight, including, as you said, the very important leading role of Black women in the origins of the reproductive justice movement. And I should say we do acknowledge the shortcoming of our composition of our panel tonight, that we do not have a person of color, on this panel. And we wish you well, Katherine, as well, with your being 9 months pregnant. And again, so glad you could join us tonight. It is now my great pleasure to welcome our third panelist, is a friend of mine and a constituent who has visited multiple times, visited us at the State House multiple times, Dr. Erin Tracy Bradley. Dr. Bradley is an associate professor in obstetrics, gynecology, and reproductive biology at Harvard Medical School. She's a past national chair of the American College of Obstetricians and Gynecologists Junior Fellows and was the first young fellow on ACOG's executive board. She's also a past chair of the AMA's Women Physicians Congress, and she has served on several Massachusetts Medical Society committees. Dr. Bradley has lectured and published about many different issues, including health literacy, maternal mortality, fetal alcohol syndrome, intimate partner violence, legislative interference in the practice of medicine, and human trafficking. She attended medical school at Georgetown University and also received a master's degree from the Harvard School of Public Health. Dr. Bradley, it is wonderful to see you again and to have you with us tonight. Thank you for being here. So perhaps you could tell us a bit about, what has motivated and really inspired you in your incredible career, and share with us the perspective about what is at stake for clinicians and their patients in this fight, and where you see reproductive justice advocacy heading in Massachusetts.
Thank you so much for that very kind introduction, and I'm really honored to be with these panelists. I had the honor of working with Katherine Rushfirth for a number of years at Mass General, and I'm so excited about all the work she and others are doing. I do come to this sort of a circuitous route to this place. I want to address some of the hesitation a lot of people have to talk about this tough subject. I think prior to the Dobbs leak, I think a lot of people were often even shy talking about abortion in a lot of social circles. I know growing up as an Irish Catholic myself that there was just something that people didn't talk about. So I want to acknowledge that really, most people don't set out because they want to have an abortion or because they want to provide abortions per se. We all believe tonight that women need to have the access, people need to have the access to make choices about their own bodies. And if you're going to try to restrict abortion, the way to do that is improve access to contraception. Policies that make abortion illegal do not reduce abortions. And we know that from a lot of data internationally. And indeed, there's very well articulated research that shows that when countries make abortions illegal, then the number of deaths by botched or unsafe abortions dramatically increase. And a recent paper said that 5 million women every year are hospitalized around the world for abortion-related complications, and that it's leaving about 220,000 children motherless around the world in countries where it has been made illegal. So it is heartbreaking, I think, for all of us to realize that 58% of women now of reproductive age, that's 40 million women, now live in, and people who could become pregnant, live in states that are hostile to abortion rights. And there's so much misconception and misinformation about this. One of the biggest studies looking at patients that had abortions, called the Turnaway Study, showed that those patients that wanted to get abortions and were turned away for various reasons. This is at 30 different centers across the country over a 6-year span, 1,000 patients. Those that were turned away from getting necessary health care and couldn't get abortion, this is prior to Dobbs, had a 4-fold increased risk of poverty, increased physical violence, increased single parenting, increased medical complications of pregnancy, and tragically 2 out of these 1,000 women actually died when they were not able to get an abortion. And we're already seeing data coming in from other parts of the country that are hostile or banning abortions outright. A recent study showed women who were admitted with premature rupture membranes. So if someone breaks their water earlier in the pregnancy, say at 22 weeks, and we consider the due days around 40 weeks. If someone breaks their water prior to the time that we think the baby might survive, in states like ours, we counsel patients and we are very sympathetic and heartbroken for them that it's a horrible outcome, but we want them to survive and have another pregnancy. And now in other states, they can't go ahead and deliver patients at that juncture. And recently, a study out of Texas showed that 60% of patients already have a significant increase in morbidity or really bad outcomes because they can't deliver those patients and offer them the right kind of care, which I think it's so important to realize that abortion is essential health care. In fact, about a quarter of women in this country have an abortion at some point. And a forced continuation pregnancy increases the risk of complications. Tragically, we already have a lot of health disparities that I'm sure will come up tonight. Black women tragically die at a rate of threefold time of white women when controlling for all other things. And we also have to realize that the longer women or people are forced to remain pregnant, if they can't get access to care, the higher the risk of complications if they do eventually have an abortion. Indeed, 0.3 out of every 100,000 abortions happen before 2 months of pregnancy, but only 6.7 happen after 18 weeks out of 100,000. 6.7 out of 100,000 happen after 18 weeks. That's a 20-fold increased risk of medical complications. Access to safe, legal abortion help patients feel supported, decreases depression and anxiety. Criminalizing it, which I'm sure we'll talk about, really affects the duty of care. I know friends from across the country that can't provide good care to patients. If patients come and they want a termination or they have medical complications and should have a termination for their own health, my friends in other parts of the country now cannot offer that. And that really puts a barrier in care for those patients. And the physicians and the midwives and those providing for them are distraught, and they're watching them get potentially ill when they're forced to continue these pregnancies. Indeed, the risk of maternal death for childbirth is 14-fold higher than for abortion. Abortions are medically much safer than many procedures that are routinely done, including wisdom teeth, cancer screening, colonoscopies, and plastic surgery. So we know it's a safe procedure. We know it's a necessary procedure. And the untold effects of this Dobbs decision have resulted in handcuffing providers and providing care for patients for a whole host of things. One example is ectopic pregnancy. So a pregnancy that is not inside the uterus, that's outside of the uterus, is a life-threatening condition, eventually. When we make the diagnosis, we can treat it in Massachusetts very easily with medication, less frequently, or if diagnosed later, with surgery. In states where it is now illegal to provide abortions or to terminate a pregnancy with a heartbeat before the mother's life is at risk, I have friends in other parts of the country that are literally admitting patients and watching them bleed internally until they can say now it is indeed the mother's life is at risk. And we don't know when that decision can be made. And it's heartbreaking to watch women potentially needing care and unable to get care. And in more mundane things, like methotrexate is a medicine that we use for ectopic pregnancies. It's used for things like arthritis. And there are patients now in other states that are being denied that medication just because it is used to terminate a pregnancy that is in the wrong location. So we worry a lot about access to care. We worry about distrust. We worry about whether providers are going to practice in these parts of the country that can't really care for patients legally, or that might end up in jail or losing their medical license. And these are already parts of the country that don't have enough access to begin with. I know that the senator mentioned that we don't have enough access as it is, and even in this state, which I'm so happy to be working in. We know nationally already there's data, increased number of women that are trying to have permanent sterilization because they're so afraid they're not going to be able to get reproductive health care. And we know also that abortion pills by mail has become a significant increase. My apologies. We know that increased maternal mortality indeed is already happening at a higher rate in states that have restriction to abortion services. So we worry so much that these rates are only going to get worse and worse. I mentioned already the racial and ethnic disparities, and I worry that there won't be enough providers for other services too, that people are afraid to practice in these environments because they can't provide the care that they should, that these are already counties, often rural communities that don't have OBGYNs, and it's going to be so much harder to get care for all sorts of health conditions, not just for reproductive health care. In other countries, like in Poland and Ireland, it took the real tragic death of totally preventable complications related to pregnancy for women to get care they need, and for the laws to be overturned. I'm super afraid. We're all very, very afraid that we're going to start seeing real horror stories. We've already seen the horror story of the 10-year-old girl who was a rape victim who had to travel to another state, and the corollary where the physician that provided her compassionate care in that other state became really persecuted and potentially even prosecuted. They're even threatening that in that state. So it is a very frightening time to be an OBGYN. It's a frightening time, frankly, to be a woman of reproductive health age, or any person who plans to do childbearing. I've had patients moving into states that have restricted access, and I have patients that have changed their minds, that they were too afraid to move to those locations because they know that their health could be in peril. So this is a very, very serious, dark time, I think, in our country. And I hate to be all doom and gloom, except to say I'm really, really happy that we're in this state where Senator Lewis and people in the Roe Coalition and all the people on this call are really trying to make it better and safer, more equitable, not only for our patients and people here, but for those that might seek our care. So with that, I will close my formal remarks, but I greatly look forward to any discussion that we may have. So again, thank you for having me today.
Thank you so much, Dr. Bradley. Just thank you for sharing your expertise with us. Just unbelievably sobering, a lot of what you shared with us. And it is frightening, but we have to push ahead and do everything we can here in an area that we have some influence in our own communities, in our Commonwealth. I draw strength from knowing that we're not alone. There's many others in other states. And even in states that have banned access to abortion or restricting it, there are people there who are fighting to get, to change that. And so I draw strength and hope from that. And having these kinds of conversations and dispelling misinformation and getting good information out into people's hands is very much a part of that. So we're going to move now to our discussion with among our panel members and with our audience. And again, really appreciate everybody who's joined us tonight for this conversation. Again, a reminder, anything you want to ask one of our panelists or any feedback you want to share with myself or our panelists, please just go ahead and type it right into the Facebook comments, and then we'll bring that up onto the screen. And a reminder also that there's a resource guide that my office has put together, and that's also something that you'll see a link to in the Facebook comments as well for further, additional deep dive reading. So Zach, I think we have our first question. So let's go ahead, if you don't mind putting that up on the screen. Great. So the first question is about the reproductive justice in terms of what that really means and the origins. And I should say, there are a variety of terms that we've been using tonight. We've obviously mentioned reproductive justice, but also reproductive rights, reproductive health care, reproductive equity. And these terms are not the same. They are, they do have different meanings and different focus. And I think it's important that we kind of unpack that in the conversation tonight. So good. I think, Katherine, you may want to get us started on this question because you did bring this up in your opening remarks, including the origins of the reproductive justice movement. So maybe you could take a first stab at this question.
Yeah, certainly. And again, I just want to acknowledge sort of my limitations in answering this question, and would really encourage people to engage with organizations like Sister Song, which are really at the forefront and certainly the leaders in this. But as you said, Senator, sort of not using the terms reproductive rights and reproductive justice interchangeably, because reproductive justice is a very sort of specific history and legacy. So reproductive justice is really understood through a human rights lens around personal bodily autonomy. And it would be the right to have children, to not have children, and also to parent your children in communities that are safe and sustainable. it obviously, those are concepts that certainly have been within, Black communities, trans communities, Indigenous communities for decades, but I think it's cited as really kind of coming to convalescing in 1994 in Chicago with a group called the Women of African Descent for Reproductive Justice. And it is very, very explicitly a response to, at the time, and could argue, today, it was a response to the fact that the largely white, cis, middle class or upper middle class feminist movement or reproductive rights movement was actually not able to be responsive to the needs of marginalized people and communities. And also that white feminists were willing to compromise in lots of ways, sort of had reached political compromises that really were to the detriment of people of color or disabled people or trans people. And so that was sort of the explicit critique and sort of the how it's, I think, part of the power of it today. So I'll let you know, like when I went to I went to midwifery school, I went through midwifery school and really never heard the term. And so one of the benefits of learning from it, not only is it a much more expansive and intersectional framework, but it has definitely helped me kind of unlearn some of the rhetoric or some of the paradigms that I certainly, as a white feminist, had been sort of absorbed about, abortion. I mean, I probably had things like that I probably have pins that say, my body, my choice, or that abortion should be safe, legal, and rare. And there wasn't really a lot of analysis with my, some of those things in terms of, it's not just as simple as choice. It's really about the structures that prevent access. And also the stigma that we're attaching to it by saying it needs to be rare, and bringing it outside of a healthcare space. I think the thing that it feels so engaging and exciting and kind of sustaining in the movement is really the possibilities that reproductive justice opens up. And I got a beautiful email the other day from a colleague, and it was about white allyship around in the criminal justice sphere. But the way that they sort of phrased it was that, part of why they, as white people, were standing in solidarity with Black abolition movements was because these Black-led movements, the world they were going to build, would have been safer for our younger selves, and our families would have had what they needed to thrive. And it's a beautiful quote on its own. And I actually thought, I was like, that is a perfect way of thinking about reproductive justice, that if we had actually followed it from the beginning, if it was the lens we saw all of this work through, that things would have been better for our younger selves. And you think about all the paths that we all go through, or so many of us go through in our reproductive sexual lives, whatever it is, whether it's sort of painful medical interactions or coercive sex or birth trauma or postpartum depression or astronomical childcare costs, like you name it, that all could have been better if we had actually really followed it. And I think we have an opportunity now to follow it and to have that be the framework that we move forward with to make it better for our children, certainly.
Great. Thank you so much for that. Claire or Erin, did you want to weigh in as well on this before we go to next question?
Thank you, Katherine, for laying that out so beautifully. I think that was a really wonderful little brief history, and I just wanted to add that I think one of the reasons why it's so important to work and approach our work through the framework and the lens of reproductive justice is I think that it shows us how it is impossible to ignore how interconnected all of these fights are, and how it's so important to be thinking about the intersections of different pieces of social justice work, right? Like we can see across the country that the state legislatures that are banning access to and restricting access to abortion are the same ones that are banning access to gender affirming care and to trans health care and to comprehensive sex ed that talks about sexual orientation and gender identity. They're the same ones that are also passing voter ID laws and restricting access to the polls in particularly Black and Brown communities. And so I think it really sets this framework for us to approach all of these different pieces of work that are so interconnected, and shows us a vision, I think, as Katherine said, for how our society could function better for each and every person in a more equitable way should we work towards achieving that.
Great. All
Yeah,
right. Yeah, please go jump in, Dr.
Yeah,
Bennett.
more concrete. I so appreciate all of your eloquence, both of you, all of you. I do think something that we do worry about in Massachusetts and in the states that do have great protection thanks to our laws is that those that do come to seek care from our state, from other places, are going to be people with means, and that the disparity is only going to get worse on all the issues that Claire just outlined, you know, and all those different aspects of healthcare. So this is just going to be a domino effect in so many different ways, and so many strides we've made it as a country and as a global community that it's just going to make the disparities worse. So I think talking about justice is essential when we're talking about access to care, particularly when access is being denied for those without means.
Right. And, you know, and as you said, for folks who would never be able to travel to Massachusetts, never mind even travel within their own state, that those are going to, you tend to be people of less means and disproportionately people of color. But, you know, even here in Massachusetts, we have very significant racial and ethnic health disparities. Certainly when it comes to reproductive care, that already came up tonight in terms of maternal health outcomes, but in other areas of healthcare as well. Many kinds of chronic illnesses, and you know, there's a lot that you know, that we need to do better right here in our own backyard. So reminded everybody to please go ahead and put any questions you want to ask any of us in the Facebook chat. And Zach, if you want to maybe bring up the next question. All right, so sort of building on the discussion we just had, you know, if we were sort of a vision of what that world could look like with true reproductive justice and freedom, let's start with Massachusetts. Let's say, because we have at least, you know, we have some influence and control over that. So what would that look like? And maybe, Claire, if I could put you on the spot, you know, you did mention the Beyond Roe agenda, which has many elements, I think, of what we would look like to try to accomplish. So maybe we could start there and then build on it.
Absolutely. I think that's a big question, and important to, I think, find ways to feel optimistic, especially in what's been a heavy few months since the overturn of Roe. But particularly when it comes to future advocacy in Massachusetts, I think we have a huge opportunity, as I mentioned before, to make sure that we're really understanding the impact of the Dobbs decision on clinics, on hospitals, on providers, and on our healthcare system more broadly. And so I think we need to make sure, in terms of specific ideas, to make sure we're collecting data appropriately to understand the scope of the crisis, making sure we're thinking about financial barriers that may still be in place for people accessing abortion care and the full spectrum of pregnancy care and reproductive health care, and finding ways, I think, to combat misinformation that is really going to be a problem, not only for people who, as we mentioned, who do have the means to come from other states, but even people here, I think, are confused and don't understand the state of abortion access in Massachusetts and how it relates to the federal government. We need to make sure that folks understand how to navigate legitimate care and don't end up at places like crisis pregnancy centers that are purposefully manipulative and purposefully try to dissuade people from accessing abortion care. I think misinformation is really what fuels not only the crisis pregnancy centers, but which they contribute to as well, but also the anti-abortion movement. And so I think we have to work together with the legislature and with advocates to combat that.
Yeah, I consider myself someone who's, you know, been reasonably well informed on these issues, you know, through the years, and just to show how much we all have to learn, and when it comes to the challenges that are facing people in accessing reproductive care, you know, I had thought that that on our college campuses, that the health centers would most certainly provide access to full scope reproductive care, and would include, you know, access to abortion services, or would, if they didn't provide it right on the campus, you know, health center or clinic, they would be able to refer, a woman to a clinic. And, that is just not the case on so many of our campuses. And that is the demographic, young women where, we see the highest rates of unintended pregnancy. So that was how I came to become a champion along, as I mentioned earlier, with Representative Sabadosa for legislation to try to change that. But I mention that because there's so much that I think, one of you, I think, mentioned earlier that almost like before the Dobbs decision, we almost like never would even refer to abortion. We just like didn't want to talk about it, and really, and that does obviously lead to, to a stigma that goes with it, and we need to, completely, do away with that. So let me turn to Katherine or Dr. Bradley. Did you want to comment further on this question?
Yeah, I can. I mean, it's a lovely question. I think it allows for that sort of reimagining, and I think as Claire said, in these pretty dire times, I think can feel sustaining as well. I mean, I keep thinking about the word joy. I mean, I think that when you think about sort of full justice and freedom, I think for people who choose to start a pregnancy journey, are going through a birth journey, or entering parenting, our hope for ourselves and for anyone we love is that it is completely infused with joy for them, and support and empowerment. And for those other times, for sadnesses, for disappointments, that people are surrounded with care that sees them as a whole person, that has dignity to it. I would sometimes have midwifery students, and I would talk to them about kind of what our role is, and I was like, we can't always spare people sadness, but what our goal is, or what our hope is, that we can spare them trauma. And I think there's a lot of trauma that goes along with reproductive care for a lot of people. But no, it certainly is a great exercise to think about of what it really would look like to have, again, thriving communities, thriving families, and then think about like what do we need to do to get there.
And I'm so glad earlier in the discussion, I think you also brought up, the importance of so many of the surrounding services. I mean, a great example, right, is childcare. Mm-hmm. And, the fact that we don't, that it is so difficult, even in our state, to have access to high quality, affordable childcare and early education, the ramifications of that when you're trying to, raise a young family. And just that's one example, but there's so many wraparound, right? When you think about what true reproductive justice and joy, as you said, would look like.
Yeah, if I could just add to alluding to what Katherine mentioned earlier about the social determinants of health. So I think we can't get to a place of joy and justice and freedom without addressing some of the core issues that families are struggling with every day, particularly those in marginalized communities. And Katherine was instrumental in us doing this at Mass General, but we now, for every patient that comes in to see us in the OB sessions, we try to identify, for people that don't know what social determinants of health mean, there are other parts of their lives that might impact care. For example, do they have transportation to get to a hospital or a provider? Do they have food? Are they worried about where their next meal is going to come from? Do they have housing? And these are things we never really, honestly, as a profession, dealt with head on with every patient. And if we don't address the fact they can't get to the hospital or they don't have food on their table, they're not going to be thinking about vaccinations and things that are, what we think are really pressing issues if they don't have enough food or housing. So I think as a profession, we've all been trying in Massachusetts to do a better job at identifying other factors that we should address in trying to get to a place of joy and freedom for all patients.
I think that's such an important step forward from our healthcare providers, and I'm so glad to hear that MGH is doing that. I know BMC, Boston Medical Center, has been a real leader in this as well, and I used to serve as the chair of the Public Health Committee before, and just thinking about social determinants of health and how our healthcare providers can play such an important role. And obviously, I've never been through pregnancy myself, but I can only imagine that when you're in that situation, how all of these factors in terms of food security, housing, mental health supports, all of that becomes, even more critical to your well-being. Let's see if we have another question at this point. All right, great. So, putting yourself in the shoes of our audience and just kind of, lay people, what are some of the ways that you would advise folks to take action? Because so many people, are so upset about the overturning of Roe v. Wade and what we are seeing in so many parts of our country, and what are the kinds of things that people can do, to channel that advocacy. Maybe Claire, do we want to go to you first?
Sure, happy to jump in there. There are so many ways to be contributing to reproductive healthcare advocacy right now. I think locally you can, find a clinic to support. You can find I'll give a plug for ourselves. You can sign up to volunteer with Reproductive Equity Now. I think when it comes to assisting in other states, I always like to lift up abortion funds, which are for decades are community-based organizations with grassroots expertise and connections that's really the network across the country of funds that have been stepping in to help people financially be able to afford abortion care for so long. And so you can, there's a national network of abortion funds has a great website. You can learn about funds in other states. You can donate if you have the means to do so. I think you can also, if you have the means, if you're looking to make a financial donation, support independent clinics across the country as well. An easy way to do that is to go to keepourclinics.org. And then I would say if you're looking to donate your time, there are a number of states where abortion is literally on the ballot in November via ballot referendum. And so you can be learning how to talk to voters in other states about why abortion is so important to keep legal and protect and expand access. There are referendums in I won't be able to list them all off the top of my head, but Vermont, Pennsylvania, Kentucky, Michigan, and there are organizations on the ground there that will gladly take your volunteer hours to be contacting voters to make sure that they're making a plan to vote on November 8th.
Terrific suggestions there. And just as a reminder to everyone how important it was and impactful when we saw the voters in Kansas vote to protect abortion access in that, very conservative state. So, again, being involved in some of these battles that are happening can really, make a big difference. Did others want to weigh in here?
Yeah, I mean, I think educate yourself on also where in Massachusetts we are falling short. Mm-hmm. And therefore, like what legislative agenda or how to engage your lawmakers. And Claire's organization, Reproductive Equity, has a wonderful website with their 21-point plan. I think specifically around, a lot of people don't realize that we still have pretty massive abortion restrictions for young teenagers. So if you are under 16, that you either need to get a parental consent or you need to go in front of a judge to be able to access abortion. And that is appalling for lots of reasons, but it also is incredibly isolated to abortion care, because I could see a 15-year-old in my clinic and give them STI testing, PrEP, prenatal care, birth control. But if they asked for an abortion, I would not be able to do that without their parental consent. The other thing is on a local level is also find out what's going on in your public schools in terms of like comprehensive sexual education. We do not have a universal sexual health education curriculum in Massachusetts. We had really struggled to pass something that was medically accurate, queer inclusive, sex positive. I mean, things that you would hope that would really kind of empower young people in their sexuality, we don't have. And then certainly, there is also a lot of midwifery restrictions here in Massachusetts, which are absolutely impacting health outcomes and maternity care access. So if you follow the Bay State Birth Coalition, they're a great advocacy group for lots of different midwifery action advocacy. And I'll tell you, we will be lobbying hard next year in the next legislative session. So certainly, I think engaging people, I think, are surprised. I think we can assume that Massachusetts is further advanced than it is in a lot of areas in reproductive health. So certainly kind of staying engaged and keeping your elected officials accountable.
Completely agree on all the points you raised there. And I want to particularly mention how frustrating and disappointing it is that we have not in Massachusetts yet ensured a comprehensive age-appropriate sexual education curriculum in our schools. That there's a bill some folks may be familiar with called the Healthy Youth Act, and that bill has actually passed in the state Senate on a bipartisan basis, multiple times, and unfortunately just has not made it through across the finish line into law. So that's a great piece of legislation for folks to weigh in on. It is pending in the Massachusetts House of Representatives right now, and they could still take action on it. And you totally agree, we need to get that done.
If I could just add too, I agree with everything that's been said. Trying to stay educated about what's happening. I know that the Guttmacher Institute has really helpful analysis of what's going on in different states that's regularly updated. The New York Times has a clicker of what's happening with different state laws. I think that a lot of us, if anyone has contacts with people in other professions in other states, because we have learned how important voting is. For those who didn't realize how important voting was, this was a clear example of why voting is so essential. And medical organizations historically, like the AMA and other big umbrella organizations of all physicians, have been really reluctant to take on this issue. And the AMA has come out strongly opposed to Dobbs, and 75 medical organizations signed on in opposition to Dobbs. And I know I've spoken to other specialty organizations where they say that it's not their lane. So we need to convince other people that have anyone they care about in any other states that this isn't everybody's lane. And so trying to influence the vote in other states or in other organizations that can influence the vote in other states. I think we need to use every avenue of advocacy we have to improve the education of others and to try to get people to vote.
Great points. And again, highlighting the intersectionality of this conversation tonight with other basic human rights, like we've mentioned, voting rights, for example. Great. All right, Zach, do we have another question? All right. So let's see. Post-Roe, are you noticing changing attitudes among care providers? Maybe Dr. Bradley, I'm not exactly sure what the question's getting at, but you may have a better idea. Maybe you can take a stab at it.
Yeah, it's a tough one. I will say we had our annual ACOG meeting, right? American College of Obstetricians and Gynecologists. It was literally the week the Dobbs decision was leaked. So it was before Dobbs was, and just watching how all the OBGYNs at this meeting, there are probably, thousands, probably 5,000 OBGYNs at this meeting. And people were just completely stunned, and we tried to figure out how to even begin to tackle it. Some were focused on training, because now half of OBGYNs essentially are not going to have access to this kind of training, which is going to affect all those patients down the road. Mm-hmm. Some were focused on advocacy and how to try to affect laws that we've talked about a number of times. And some were focused on clinical care and provision of care, which is obviously being dramatically hurt in 48% of eligible people who may become pregnant, any of these services. So I think that post-pandemic, many of us have had very high levels of burnout because of the misinformation and the, showing up for work with a deadly virus without pre-vaccination, without knowing if you would go home safely to your family. So I think providers were already at the brink of burnout. And I read somewhere 1 in 5 healthcare providers have been threatening to quit or are leaving healthcare. I think this Dobbs decision, particularly in OBGYN, has been times a bajillion in states where they no longer can provide care to their patients that they know their patients need. So we don't know yet exactly where this is all going to end, but I can only imagine in talking to my friends practicing in these states, they are distraught and heartbroken.
Anyone else want to weigh in?
Yeah, I mean, I think again, I'm a midwife and Erin's an OBGYN. We're kind of in the world of abortion providers, but I think it is sort of forcing a question, certainly of like, I mean, certainly like how did this happen? Like this thing that seemed that so many people assumed was like out of the realm of possibility. And I think there's also a feeling of like, how did it become so vulnerable, and how did it become so siloed, and how did it become so stigmatized? So certainly within, I think conversations with nurse practitioners, I think conversations with physician's assistants, like other advanced practice clinicians, there's sort of the feeling of like, all right, this hasn't been our wheelhouse, but there's no reason it couldn't be our wheelhouse. There's no reason your primary care provider or your pediatric provider couldn't be providing medication abortions. Right. And I think even for midwives that haven't historically sort of had that part of their service, I was really proud at MGH. I was the first midwife to provide abortion, and now it is standard care for the midwifery service. So I do think that there's, and the more that's out there, the more that it certainly, like, there's so much interest in providing the care. So I think that's like a larger conversation for us to have in the health system of like, why have we restricted access to like local clinics or certain specialties when really this could be a much more expansive reproductive health workforce?
Can I just add one thing to that?
Yeah.
I'm sorry. I think one of the challenges though with the medical abortions is I know many providers want to do medical abortions, and we've had the luxury of many services approaching our department about how they can prescribe. The reality is they're not always successful, and a certain percentage will need surgery. And many hospitals are already at capacity, and already surgical volume is exceeding what we can provide with the infrastructures we have. So I think when I read that Globe piece yesterday, part of the thing that struck me is, and I have 2 daughters, my 3 kids go to UMass Amherst, and in thinking through that law, they need to have a relationship with the hospital that can provide surgery when the medications don't work, and they need to have capacity at those hospitals. So I think a lot of these are much more complicated when it comes to logistics of how to really provide this care, that I think a lot of people are struggling with how to help, but then make sure people, because you can't give medication, have someone hemorrhaging and not able to get to an operating room. So we need to have some sort of protocol and some sort of way to provide that care. So
that sort of leads, to something I've been wondering about, which is, now that medication abortion is more readily available and well accepted, and again, it's only available for what I think the first 9 or 10 weeks or so of pregnancy. So it certainly isn't a solution in all cases. But what kind is, in terms of thinking about women that are in states that will have now completely banned or severely restricted access, to what extent will this be an option for them? Maybe it's sent through the mail, or, can you, given what you said, Erin, about that, that can be sometimes there can be risks associated. But could you maybe speak to that? Because I'm sure that is a question for some folks as well.
Yeah, I don't know if Claire has more current data on this. I know that there was a movement by the President Biden and trying to get the protections for the telemarketing for this and telemedicine for medical abortion. I think that's still been held up at the federal level. These things are all subject to change based on elections. But I think that what's going to happen is what's happened in states prior to Roe. If people had attempted abortions that were not successful, they came to the hospital and they got care. I think that will be what's happening. People will just show up. Mm-hmm. The key will be, and I know that I've talked to emergency medicine colleagues in other states where they're going to provide care. And I know that there are some states that are really trying to criminalize even people that provide care when someone had started an abortion at home, and that there needs to be a real way to protect people and have them feel empowered. And right now, with the federal government, there's some protections, and in the state, there's certainly the state law put protections into providers. But I think it might be a don't ask, don't tell as far as how, I know when I've trained in a Catholic hospital med school, and we would do tubal ligations, but we would call it tubal surgery. And we would give out birth control, but we would call it hormonal therapy. I'd imagine people might have to be creative just to protect themselves legally so they don't end up in jail or losing their licenses, because we have to take care of patients that show up on our doorsteps.
And I want to sort of add to or just, to Erin's point about the lack of, which is the reality of today's system, the lack of OR space and people who could provide what we call a DNC, like a surgical intervention if a medication abortion is not successful or that it's causing too much bleeding. Again, this is where I go back to like the system that we're told is the best we can do, or the system that we're told that we have to tolerate. You have over half the population that's has pregnant capacity. You have over half of pregnancies in this country are unplanned. The fact that we cannot fully address that and we can't fully offer people a scope of like an appropriate scope of care is misogyny in action. That is racism in action. And that's where I think, that is the truth. Like right now, there would be no ORs, and women's health or reproductive health gets like bottom of the list in terms of what we prioritize in OR space. And again, I think just naming that for what that is and recognizing those are choices we have made as a system as opposed to the realities of how it needs to go.
Thank you so much for calling that out, Katherine. And also by calling that out, of course, that means that's something we can change too. Doesn't have to always be that way. All right, let's see if we have another question. A reminder to our audience, again, we welcome any questions. Just type them into the Facebook chat, Facebook comments. All right, let's see. We have a question here so this is referring back to the Roe Act that we passed, the so-called Roe Act in Massachusetts. This was a new law we passed in late 2020. It allowed for increased ability of advanced practice providers to provide abortion care. So this would be like Katherine, you were referring also to this workforce, like advanced practice nurses, for example. How do we expand that workforce? So this dovetails pretty nicely with the conversation we were just having in terms of, again, ways to expand access to, the full scope of reproductive care, including abortion. I don't know who wants to take this one first.
I might kick it off because this is a favorite topic of mine. So yes, this is a huge success of the Roe Act. And I think it is exciting to feel like so many of us who are advanced practice clinicians can now really be part of this expansive work. I think within Massachusetts, we need to look at a few different things that have very, very much limited the capacity and the optimization of advanced practice clinicians. And so first off is training programs, which this kind of indicates. So there is hardly any federal money that goes into nursing education, and that would include certified nurse midwives, and that would include nurse practitioners. So a lot of programs are really limited in their numbers, and they're they find it very, very hard to find clinical sites. And when I don't have the exact statistics, but it's something like tens of thousands of federal dollars go into medical education, and it's like $1,200 goes into nursing education, like per student. So that's something on a federal level that actually the Momnibus on a federal level will address. The second thing, and I think a lot of medical lobbying groups and medical organizations need to take a long, hard look at, is how much they fought advanced practice clinicians for becoming independent providers. Fought that tooth and nail for years. And certified nurse midwives have it now, and thanks to like a lot of our allyship with FACOG, and nurse practitioners have it recently. But again, like that rhetoric of like, this is less good care, these people are not safe, they need physician oversight, has absolutely hindered the ability for our advanced practice clinicians to work to the top of their license. The final issue, which absolutely is still the case, is that we are struggling to get Massachusetts to pass legislation that would guarantee midwives, and I would include nurse practitioners. I don't think they have legislation on this yet, but midwives to have the same reimbursement as physicians for the same service. Mm-hmm. And we are the only state in the Northeast that does not have that. So if I place an IUD and Dr. Bradley places an IUD, I am probably getting compensated maybe 60 to 85% of what she's getting compensated. It's the same service, but that means that you're going to have hospital systems and medical systems that really are not going to want their advanced practice clinicians providing these services because they have to take an economic hit on that. And again, to your point, Senator Lewis, like sometimes it's dispiriting to realize that these are kind of man-made barriers, but of course we have the option to change them. So I think those are three places to start.
If I can add something too, I think this is something our profession is struggling with on the physician side. There's X amount of clinical exposure, particularly to surgical terminations. I mean, there are X number of cases in the country per year. And half of the OB/GYN residents are losing access to the training, most of whom didn't think that was going to happen. You know, I have friends that are training in states where they have 0 abortion services. So some states that have abortion care now are trying to figure out how to potentially train those residents and fellows from other, I mean, they're fellows in family planning who are doing a special subspecialty training on abortion care and other, family planning, contraception expertise, et cetera, that can no longer do that in these states overnight. So those people are OB/GYNs who finished the 4-year residency are now trying to get that training that don't have any. So I totally hear and appreciate and agree with, I almost always agree with everything Katherine ever says, but this is something we're all struggling with, because with X number of clinical experiences happening and all these providers of all different types that need training from states that no longer have training, those that have those clinical care services provider trying to figure out how to assist training from other parts of the country and not harm training for advanced practice providers in these states and not harm training for our residents and our fellows that are already here. So it's a tricky situation.
Katherine, can you just mention again, you mentioned, I think it's a law pending in Congress that would address greater federal reimbursement for nursing education. And I've heard of this issue before.
So it's the Momnibus. I'm sorry, I don't know the House bill, but that's how, if you Googled it, and Lauren Underwood is the major sponsor of that. And both of our senators from Massachusetts, Senator Markey and Senator Warren, have also co-sponsored it. So good. That has a lot of what we're talking about in terms of advancing nursing, nurses' role.
Well, that's something that folks can also weigh in on, obviously with our congressional delegation. And, more generally, we're facing a very significant workforce shortage in nursing right now. I mean, there's been incredible burnout from the pandemic. And so, in the area of reproductive care, but in other areas of care as well. So we're going to have to really figure out ways to support our nursing workforce. All right, let's see if we have another question coming in. Great, thank you, Zach. Okay, so this question is going back to that 2017 law that we passed, and known as the Access Law, which really had to do with focusing more on access to contraception. So I know there's been some concerns, some shortcomings in the implementation of the law. It hasn't really achieved what we had intended. So it would be good to know what you feel like we need to do to make sure we realize the full goals of that when it comes to access to contraception, including emergency contraception. Who would like to take this one?
I'm happy to start. I think one of the really exciting provisions of the bill that the legislature passed this summer, Senator, that is in many ways one fix to some of the challenges we've seen in implementation of the Access Law is a statewide standing order for emergency contraception, which means that the Access Law allowed for insurance coverage at no cost of emergency contraception, but you need a prescription, which when you need timely access to emergency contraception isn't something that's incredibly realistic for folks to have to go to their provider to get a prescription. And so what in reality folks end up doing is buying an emergency contraception that's well known, like Plan B, that's available for over-the-counter sale, and they pay out of pocket. But what a standing order allows for folks to do is it's essentially like a standing prescription at a pharmacy, so that it allows you to be able to access both prescription and over-the-counter emergency contraception. There are different types of emergency contraception that might be better suited for you based on your weight, the amount of time it's been since intercourse, what have you. There are a number of reasons that you might choose one over the other. And it allows for you to access both types from your pharmacy, and importantly with insurance coverage, which means that it's available to you at no cost. So we're really excited that our Department of Public Health moved incredibly swiftly to issue that standing order in early August, just after the bill was signed. And so now our work goes towards implementation and some conversations, I think, that to work, I'm sure, with pharmacies and retail pharmacies to make sure folks understand how it changes, their internal protocols and their employee protocols with regard to making sure they have proper inventories and things like that. But it's a really, really exciting provision to expand affordable access to emergency contraception in a real way.
Yeah, and I've also heard of pharmacies that were not aware that patients could have 12 months dispensed at once, because historically I was sometimes pushing to get 3 months at a time because insurance companies were reluctant to pay in case they decide they didn't like it or want a different pill. So I don't know that everyone understands fully that the law is the law at this point still. So I guess better education of.
I think also, when I think about where the breakdown was between like maybe provider and patient or patient and pharmacy, having worked in a community health center with majority of the patients probably with limited English proficiency, is when we talk about diversity in healthcare, it is at all levels. And that like can include pharmacy, that can include, like front desk of health centers, so if my patient, would go to the CVS and their prescription wasn't there, which is probably an experience that most, like most of us have had, how people felt like they could follow up with that or ask the questions and, and that kind of how you kind of can encourage self-advocacy as well at the patient level. But I agree with Erin. I think both providers and pharmacists sometimes didn't realize that they could write for 12 months.
Mm-hmm. Good. Well, I'm glad to hear that at least the more recent legislation, has made important steps forward there in terms of the standing order, and that DPH did issue that standing order quickly. Okay. All right. So I think looking at the time, we maybe can take one more question. So Zach, do we have one more? Okay. Biggest threat to safe and empowering reproductive healthcare today. Great. So who wants to kind of take this one first? Certainly, I guess the obvious answer would be, legislators that want to ban, access or restrict it, for the most of whom are male. But what other aspects to this would you give sort of in addressing this question?
I can start. I think sort of have a fairly esoteric answer to this question, because I think it is hard to parse down to one thing. There's a quote I heard like several years ago. I think it's from a WHO physician, and what he said is, women are not dying of diseases that are untreatable. They are dying because societies have not yet decided their lives are worth saving. And if you're going to say, what is the threat or what is the issue? I think that is the issue, is that it is by far the most dispiriting thing. It is the most distressing thing, but there is a profound devaluing and disinvestment in people and in individuals and in communities. And that they follow patterns, they follow historical patterns from slavery to genocide to xenophobia to transphobia. And when I think about it in my work, in a state this rich, in a country this rich, you're really talking not about the lack of resources, but you're talking about a lack of will and a real reluctance to cede power. And so the hoarding of power and the hoarding of wealth. And I'll bring it back to neighborhood birth center and actually kind of some of the struggles that neighborhood birth center is having. So we're trying to open a freestanding birth center. There is birth center care has been shown to reduce cesarean section by 40%, reduce preterm birth by 26%, reduce low birth weight babies by 20%. These are some of the most painful, the most intransigent issues in obstetrics. And one could think that we would be like, oh, we need to scale that. We need to invest in that. But I do think it is the ceding of power again. I think there's something about midwifery, there's something about out-of-hospital birth that runs very counter to a lot of the narratives we have that can feel threatening, that can feel not part of the medical system that we have created. And so we have no federal funding for birth centers. We have very erratic or non-existent state funding for birth centers. We've got insurance companies that reimburse birth center care much, much, much lower than hospital-based care, despite the best outcomes. Here in Massachusetts, as I said, we can't get people to pass equal reimbursement for nurse midwives. We're the only one of 13 states that does not license certified professional midwives who are real experts in community birth and could staff, could scale up birth centers. And I think the result of all of that is somewhere like Neighborhood Birth Center. I mean, we're talking about working on this for 7 years. We're talking about doing like backyard fundraisers to try and raise $3 million to fund it. And, again, I think when you look at, like the power imbalance or the need for profit, that stuff is, I think, the threat. The profit, the idea of power and profit over anything related to patient experience or outcomes.
And if I'm not mistaken, Katherine, the one birth center that is open in the States on the North Shore, right?
No, so
there was
there's been two birth centers that have closed in the last 2 years. So North Shore Birth Center was open for 40 years, just closed. Cambridge Birth Center has closed. The one that's open is in Northampton. So we've got one in Western Mass. So there is no birth center care. I can't access it. It's what I would have wanted. I'm being funneled to a hospital because it's really kind of my only option. There's nothing in Eastern Massachusetts.
Wow. Well, I, for one, would be very happy to work with you and colleagues on legislation for the next session and other ways we can be we can really change that landscape, because you've made a very persuasive argument tonight.
I will be emailing you.
Yes. All right. Well, we are approaching the end of our time. It's been a phenomenal conversation. I want to just give each of you, if you'd like, just a minute or two, if you want to sort of close out, maybe summarize your thoughts that you want to leave with our audience tonight before we wrap up. Maybe Claire, we'll go back in the same order. So we'll start with you if you'd like.
Sure. Yeah. I'll keep it brief, but I really, really appreciate the conversation that we were able to have tonight. And I think it was Dr. Bradley who said that, I think prior to Dobbs, now this is very top of mind for everybody. I think prior to Dobbs and maybe even still now, people approach conversations like this with caution. And I think, from, an electoral perspective, I think especially in Massachusetts and Senator, you mentioned Kansas and other places, the values of reproductive freedom and advancing reproductive justice are winning issues with voters. Values of freedom and bodily autonomy and self-determination are issues that voters care deeply about. And the more you have conversations about it, the more those values are ones that voters come to the polls with, which I think is really something important for us to keep in mind. But I think also going back to the previous question about what are the biggest threats to advancing reproductive freedom and reproductive justice, is one of those things is stigma. And I think conversations like this helps combat that head on and helps empower people to have conversations with their family and friends, with their colleagues, and hopefully, have future conversations with their legislators and raise this as an important issue to them, all of which I think will contribute to breaking down kind of these systems of power that have been in place and prevent people from accessing equitable access to healthcare. So I think that this is a really empowering conversation to have, and I hope that folks enjoyed it and learned something, and maybe it encourages you to think about what you want the legislation that you're advocating for in the next session is at least specific to Massachusetts to be. I know I certainly look forward to continuing conversations with you, Senator, and Dr. Bradley and Katherine to talk about collaborating on that work.
I very much look forward to those conversations as well, because as as we've discussed, we've got a lot of work still to do here in the Commonwealth. Katherine, do you have some closing thoughts you want to share?
Yeah, I think, again, just to bring it back to that idea of reimagination, reimagining a system, I think the feeling that rather than sort of defining a system by the sort of feeling of scarcity, sort of this idea of abundance, that there are enough resources, there are enough providers, there are enough hospitals, there are enough clinics, that we can really therefore call out when we have fallen short there, but not stop there. And then I think the other thing is, with profound respect for people who have been working in reproductive justice for decades, what we don't, especially those of us who are, white people in this work, we don't need to come up with the solutions, and we should not come up with the solutions, but people have the solutions and they're out there. And I think the resource guide is going to talk about there's a commission on racial inequities in maternal health. There's a number of solutions they've put there that have been community guided. And I think also recognizing when we build this better system, when we build a system that truly meets the needs of everybody, there's healing in that. And there's liberation in that. And so I think that to try and end on an optimistic note to keep us going.
Absolutely. And Katherine, just mention again for our audience, the commission.
Yep. So this is a legislative commission that was, they worked for a year on a report. It's called the Racial Inequities in Maternal Health Report, a sort of very sort of interdisciplinary, diverse commission that did listening sessions all over the state. And there's wonderful things in there in terms of what we could be doing on a very kind of tangible public health legislative level to improve care.
Great. So that for folks, that report is linked to in the resource guide again, which is in the Facebook comments, and encourage you to look at it. And I also want to give a shout out to my wonderful Senate colleague, Senator Becca Rausch, because it was her leadership that created that commission. Dr. Bradley, you get the last word.
Yeah, I was just going to echo my gratitude for this conversation and for all the incredible work Katherine and Claire and you're doing, Senator. The answer to what I was going to answer the question about barriers to us moving forward, I think misinformation is deadly, and I think it's caused a great harm, and it's caused a lot of harm in this pandemic, where it's created a lack of trust between providers and patients. And I think in this state, we have a greater general understanding and acceptance of science and evidence-based practice and decision-making. But across the country, there were state laws where physicians were required by law in consenting patients for abortion to say in writing that abortions cause breast cancer, that abortions cause depression, that abortions cause fetal pain, all of which are proven not to be the case. So we are now in an era where laws are being made that are absolutely disproven when you look at the science. So I think we need to get back to a place in society where we care about data and evidence and science in both in our democracy and our healthcare settings. And I know I spend a lot of time with patients really trying to convince them that I have some wisdom to share, because they see so much misinformation on different media outlets that are simply giving bad information. And a lot of people aren't getting vaccinated, for example, because they thought the vaccines were deadly. So I'm hoping going forward, we can have a community of shared understanding of the importance of real data and making decisions.
Well, that's probably a signal that we need to wrap up, as I now sit here in the dark with the lights having gone out. So just my deep gratitude to our wonderful panelists tonight, Katherine Rushfirth, Claire Teylouni, Dr. Erin, Tracy, Bradley. Thank you so much for making time to be with us. Thank you so much for the incredible and important work that you're all doing. Thank you very much to our audience for being with us. Thanks for your questions. A reminder again to check out the resource guide, and feel free to follow up with my office as well if there's any aspects to this that you want to discuss further. Thank you again to Sarah Zyberg and Zach Crowley from my staff for organizing tonight's event. And stay tuned for our next community conversation. We haven't yet determined the topic, but we will let you know as soon as we do. Thank you, everybody, and have a good rest of the night.
Thank you, Senator.
Thank you.
Bye, everyone.